All right, everyone's favorite. Let's talk about it. End title, capnography, EtCO2. Now, I have a couple different things here. Okay, a couple different things over here that are explaining what you might see on your waveform capnography and why it's beneficial. One of the big ones, if you see on the top there, let's say we intubated somebody, we get positive waveform capnography. Let's say we're doing CPR and we shock the patient, and then all of a sudden you see a flat line in your end-tidal capnography. What just happened? Okay, what just happened to our tube? We might have lost it. Okay, end-tidal capnography can tell us if the tube gets dislodged, which is a great thing to know. The next one, a decrease in end-tidal capnography. There could be an obstruction. Maybe there's a mucus plug, or maybe there's something wrong with the tube. Okay, maybe somebody tightened down the endo lock and they're now limiting the amount of air that's going in there, and now our patient is being hypoventilated. There's things that we need to consider that can be happening. We can use end-tidal capnography as a CPR assessment. As long as my end-tidal remains greater than 10, I can say that I have decent quality chest compressions. The sudden increase in end-tidal capnography tells me that my patient could potentially have ROSC. And this shit is getting harder to tell nowadays because we're using mechanical devices to do CPR. What's wild, man, I tell people, I was using a Lucas device on this one woman once. She was in asystole, and I had an end-tidal capnography of 40, the whole code, just because of how good the compressions or the quality of compressions from the Lucas device is. So trust me, I wasn't going to see a sudden spike in an end-tidal capnography. Those devices do way better chest compressions than me or you. Okay. And she was in asystole. Anybody want to take a stab at the bottom photo that I added down there? What do you guys think that is? Coming off of med. Yes, it's a cure clef. Okay. So a cure clef is when your patient is on a sedative. Okay. And you have the patient intubated. If you start seeing notching in your intubation, in your end-tidal capnography, your patient's sedative is wearing off. Now, I always tell people, pay close attention to that patient while they are sedated. The first thing that you typically are going to note is they start blinking. If you don't notice the end-tidal capnography, the patient's going to start blinking on you. Once they start blinking for a little bit, the next thing that they're going to be doing is reaching for the tube. Don't get in that situation. Pay attention to your monitor. Pay attention to your patient. Okay, give them a little bit more love, if you know what I'm saying. Got some more stuff here when it comes to end-tidal capnography. And I love talking about end-tidal capnography because it's freaking awesome. And it's something that we can utilize to diagnose a lot of shit. In EMS, we typically don't diagnose necessarily. We're not doctors. But at the same time, if you know what you're looking at, it makes things so much easier to know exactly what's happening. The top one that right up here is right here. We have normal-ish plateaus. Okay, we have these peaks up here that are flat. That is considered normal. Okay, this patient is tachypnic. I can tell you that. The patient's breathing fast because of how narrow these end-tidal waveforms are. It should be a lot more like longer, and that's more of a normal look. But up here on that top one, we see that our end-tidal capnography is 40. 35 to 45 is considered normal. We got normal end-tidal capnography. Let's take a look at the second one. The second one's an interesting one because if we look at 40, it's close to normal, maybe even a little bit higher. Some of them look a little bit higher. And that tells me a lot about that patient, that my patient might be retaining CO2. Okay. But also we have what's known as a shark fin appearance. Okay, a shark fin appearance when we have this sudden decrease, okay, up and then a sudden drop. That is indicative of lower airway obstruction, wheezing, right, in a patient that either has asthma, anaphylaxis, or COPD. That is lower airway obstruction. Again, that patient is tachypnic. The interesting part about end-tidal capnography sometimes with these patients that are having a really hard time with exhalation, they're having a difficult time with the exhalation, is they get this really long shark fins. And that's when you hear that real long expiratory wheeze. Not uncommon to see. And sometimes I'll have a partner with me on the truck, and they're listening to lung sounds. And hey, Mike, yeah, I hear rails, and we have end-tidal capnography on, and I can just look at the monitor and say, "Are you sure?" Because it does not look like the patient has rails. Because if the patient has rails, it would look like the last one. Here's the last one. We have very short plateaus, right? On these very short plateaus, we have what's known as a one-to-one concentration. One-to-one concentration, and that's how it would be written. That is classic for rails, classic for crackles, right, in the lungs. They have a very short inspiratory phase and a very short expiratory phase. Remember your IE ratios for all three of these. Normal is 1 to 2. Bronchospasms can be up to 1 to 4. And then we have, for our patient with rails, a 1 to 1. Very common. Please know your end-tidal capnography. It'll not only help you on exams, but it's going to help you in real life, I promise you.